This discussion is going to be on the integumentary system, Chapter 7. Our objectives for today are to describe the primary pathology in the integumentary system, describe integumentary system manifestations and other systemic pathologies, discuss thermal injuries including classification of burns, discuss signs and symptoms of skin ulceration including vascular, neuropathic, and pressure-related ulcers, and discuss integumentary red flags such as signs and symptoms of cancers, cellulitis, and spread of infection to the lymph system. Our questions of the day: a 65-year-old patient with diabetes mellitus presents with non-healing wound on their right heel. The wound is large with exposed adipose tissue and has rolled edges. There is visible granulation tissue, and the depth of the wound varies across the heel. The wound bed is moist and pink, but no muscle, tendon, or bone is visible. The patient reports mild pain, and the wound has been present for several weeks without significant healing. Based on the description of the wound, which of the following is the most appropriate classification of the ulcer? A, stage 1 pressure injury, B, stage 2 pressure injury, C, stage 3 pressure injury, or D, stage 4 pressure injury. The second question is: a 45-year-old patient presents with chronic scaly erythematosus rash on their elbows and knees. The patient reports that the rash comes and goes, but has worsened over the past few weeks. Upon examination, you notice silvery white scales on the patches of skin. Which of the following conditions is most likely responsible for these symptoms? A, seborrheic dermatitis, B, psoriasis, C, atopic dermatitis, or D, contact dermatitis. The skin is the largest organ in the body and makes up 15 to 20% of body weight. 1 in 4 people who consult a physician have a skin disorder. Skin lesions can be caused by various factors. Skin lesions can be classified as primary lesions, which is the first lesion to appear with a recognizable structure. Causes include contact with harmful agents such as chemicals or toxins, infective organism, medication reactions, physical trauma, hereditary factors, allergic reactions, radiotherapy, systemic disease, burns, and neoplasms. Secondary lesions develop when primary lesions change. Causes include scratching, rubbing, medication, disease progression, and healing processes. Signs and symptoms of integumentary disorders include pruritus, which is a common symptom of dermatologic disease affecting up to 50% of those with generalized itching, and can lead to skin damage, increasing inflammation, infection, and scarring if scratched. It is associated with systemic diseases such as diabetes mellitus, drug hypersensitivity, and hyperthyroidism. Urticaria, also known as hives, is a vascular reaction of the skin characterized by smooth, slightly elevated patches known as wheals. Wheals are redder and paler than surrounding skin and often itchy. Blisters are fluid-filled elevated lesions containing clear, watery, or bloody fluid, and causes include genetic or autoimmune diseases, viral and bacterial infections, local skin injury, and drug reactions. Xeroderma is a mild form of itchitis, which is excessive skin dryness. Skin is dry, rough, discolored, and scaly shedding, aggravated by dry climates and the use of drying soaps, cleansers, and solvents. Mongolian spots, also known as congenital dermal melanocytosis, is common in infants of Asian, East Indian, Native American, Alaskan American, African, Latino, or Hispanic heritage. It is also seen in about 1 in 10 fair-skinned infants. It is skin markings that can range from a bluish gray to deep brown or black. Typically appears on the base of the spine, the buttocks and back, and occasionally on shoulders, ankles, or wrists. It may cover a large area of the back. Deeper melanocytes appear bluish, where superficial ones appear deep brown. and is often mistaken for signs of child abuse. It does tend to fade with age, typically disappearing by age 5. Skin changes across the lifespan. During puberty and adolescence, there's hormonal changes that stimulate maturation of hair follicles, sebaceous glands, apocrine and eccrine sweat glands. Common occurrences include mild acne, perspiration and body odor, freckles due to sun exposure, and pigmented nevi, which are moles. In adulthood, hormonal changes are often caused by birth control or pregnancy and can cause temporary hair changes, hyperpigmentation, androgen-related changes can result in excessive facial hair and body hair in women, male pattern baldness or alopecia due to hormonal and genetic factors, and smoking is linked to facial wrinkles. Aging can occur due to intrinsic aging, which is natural aging process, photoaging, which is cumulative effects of sun exposure, extrinsic aging due to environmental factors. Age-related skin changes include diminished pain perception, increased vulnerability to injury, decreased vascularity, and weakened inflammatory response. Visible aging signs include gray hair and balding, excess facial hair in women, balding in women post-menopause, increased facial hair in men. Other age-related changes include lax skin, vascular changes, dermal and epidermal degeneration, wrinkling due to loss of elastin, weakened collagen, and decreased subcutaneous fat. All are accelerated by smoking and sun exposure. Atopic dermatitis is a chronic inflammatory skin disease, also known as eczema. It is the most common eczema type, which often starts in the first year of life and affects more than 10% of children. The cause is unknown, likely multifactorial, with some factors being genetics, environmental, skin barrier, pharmacologic, psychologic, and immunologic. Pathogenesis involves both immediate and cellular immune responses. Dry skin in atopic dermatitis is due to reduced water binding capacity, increased transdermal water loss, and decreased water content. Exacerbating factors include rubbing and scratching, frequent hand washing, or water exposure. Clinical manifestations in infancy are red, oozing, or crusting rash. In childhood and adulthood, it can become chronic with dry, thickened, brownish gray skin, a localized rash on the flexor surface of elbows, knees, neck, face, eyelids, hands, and feet. Hand-foot dermatitis can be significant. There is no cure, but 90% of cases are manageable. The treatment goal is to break the inflammatory cycle to reduce dryness, cracking, itching, and scratching. Contact dermatitis is an acute or chronic skin inflammation due to chemical, mechanical, physical, or biological exposure. It is one of the most common environmental skin diseases and can occur at any age. Older individuals may develop delayed hypersensitivity. Common sensitizers include metals such as nickel or chromates that are in leather and tanning. That are in leather tanning, skin products such as wool fat or lanolin and moisturizers, medical substances such as topical antibiotics, and other common factors are rubber additives and silicone in rare cases. Clinical manifestations in the early symptoms about 1 to 2 days post-exposure is intense pruritus or itching, erythema, which is redness, and edema, which is swelling. As it progresses, blistering, oozing, crusting, and scaling can appear, And in chronic cases, thickened skin, prominent skin markings, and pigmentation changes can occur. Diagnosis is based on a detailed history and examination. Patch testing may identify the causative agent. Treatment of the primary would be removal of the offending agent, and secondary would be skin care to manage symptoms. The prognosis is acute lesions resolve in about 3 weeks. Chronic cases persist until the irritant is removed. Eczema and dermatitis are often used interchangeably, referring to superficial skin inflammation. Causes include irritant exposure, allergic sensitization, and genetic or idiopathic factors. Types of dermatitis include allergic dermatitis, irritant dermatitis, seborrheic dermatitis, nummular eczema, atopic dermatitis, and status dermatitis. It is broken down into acute, subacute, and chronic stages. It is more common in older adults. Risk factors include hypoproteinemia, venous insufficiency, allergens and irritants, underlying malignancy, and drug-to-drug interactions and polypharmacy. Rosacea is a chronic facial disorder primarily in middle-aged and older adults. Key differences from acne, since this is a form of acne, is the age of onset, which is later in life. There's a vascular component, and no pimples accompany it. Clinical presentation is rosy cheeks, nose, chin, or entire face. Triggers include sun, hot weather, and humidity, and is most common in fair-skinned individuals who flush easily. Management includes topical or systemic therapy for inflammatory papules, pustules, erythema. Chronic cases are treated with pulsed dye laser or intense pulse light for deeper skin treatment. Skin infections can result from bacteria, viruses, fungi, and parasites, commonly seen in hospitalized patients and patients receiving other treatments. PTAs may not be the primary focus of treatment in physical therapy, but are crucial in recognizing and managing these skin infections. Many skin infections are contagious, such as MRSA, herpes simplex, and athlete's foot. PTAs must prevent transmission by following infection control protocols, such as hand hygiene, PPE use, identifying symptoms of common skin infections, and reporting any suspected infections to the healthcare team. Impetigo is a bacterial infection caused by Staphylococcus or Streptococcus bacteria. Young children are at high risk between the ages of 2 to 5 years old, and older adults as well as individuals in close contact environments such as schools and crowded areas, as well as poor hygiene, malnutrition, skin trauma, and anemia. It is spread through direct contact, contaminated surfaces, and arthropods. Symptoms, it starts with flat spots that develop into blisters, that develop into pus-filled lesions. These blisters break, a thick yellow crust forms. It can be painful, redness, itching, swollen lymph nodes, and possible cellulitis. Treatment of small lesions involves soaking for 10 minutes with drying agents. Widespread infections require oral antibiotics. Cellulitis is rapidly spreading bacterial infection. Individuals who are at risk are older adults, individuals with diabetes, immunocompromised individuals, individuals with poor circulation such as venous insufficiency, lymphedema, wounds, and ulcers. Also steroid use, substance abuse, and malnutrition. Symptoms include painful, red, warm patches with sharp borders. Red streaks indicate infected lymph vessels. Facial cellulitis affects cheeks, eyes, and neck. Treatment includes IV antibiotics for severe cases, oral antibiotics if caught early, prevent reoccurrence with standby antibiotics. As a PTA, our role can be to draw a border around the infection to track progression and to take photos to monitor changes. Viral infections. The skin's response in viral infections includes inflammation and vasculation, proliferation that forms into growths. Herpes zoster, also known as shingles, is caused by the reactivation of varicella zoster virus or the chickenpox virus. Individuals at risk are peak incidences during ages 50 to 70, about 300,000 cases annually with 95% first-time infections. Symptoms include unilateral vesicular rash along dermatomes, symptoms that can occur prior to the rash, about 2 to 4 days before the rash appears, can include pain and tingling in the affected area, fever, chills, malaise, and GI issues. 1 to 3 days later, there's red papules that appear. Complications can include trigeminal nerve involvement, which can lead to eye pain and vision loss. And rare severe complications may include central nervous system infection, motor paralysis, myelitis, urinary retention, and diaphragm paralysis. Diagnosis is done with clinical examination of the skin lesions and systemic symptoms, as well as lab tests, including cultures and histology. There is no cure but supportive care for pain and itching. Corticosteroids in the first few weeks may reduce symptoms and prevent post-therapeutic neuralgia. Varicella zoster vaccine for prevention. Prognosis is generally good unless central nervous system involvement occurs. Possible scarring and vision impairments can also occur. The next viral skin infection is warts. It is caused by the human papillomavirus, or HPV, which is a benign viral skin infection. It is common in children and young adults, but it can appear at any age. Transmission is direct contact from person to person and auto-inoculation with self-infection from scratching and touching. Clinical manifestations include the general appearance, which is thick white surface with pointed projections, can be single or multiple lesions. There are a number of different types of warts. The common warts generally have rough, elevated, round surface, which is most common in the hands and fingers. Also plantar warts, which are slightly elevated or flat, occur singly or in clusters and are found at pressure points on the feet. It is diagnosed with visual examination based on wart type and location. Differentiating plantar warts from corns and calluses is through obliterated skin lines, red, black capillary dots, which are visible after shaving the wart, and pain with pressure application. Some resolve spontaneously but can be chronic and recurrent. Factors influencing treatment choice include the size, location, number of warts, pain, secondary infections, and treatment history, as well as patient age, gender, and compliance. Treatment options include topical treatments such as salicylic acid, cryotherapy, where they use liquid nitrogen or solid CO2 to freeze the warts, and acid treatments, which are applied daily and left on for 24 hours, then reapplied. There's also electrodesiccation and curettage, which is burning and scraping off warts. This is used for common and plantar warts. Fungal infections are caused by a fungi that invades the stratum corneum, hair, and nails. Superficial infections affect dead keratin layers, not deeper skin, and can spread if untreated by over-the-counter antifungal creams available, but proper diagnosis is needed. The common types of fungal infections include ringworm, which is a ring-shaped pigmented patches with vesicles or scales. It is itchy, but not caused by worms. Transmission is with direct contact with infected lesions or indirect contact with contaminated shoes, towels, or showers. Athlete's foot appears with redness, peeling of the skin, pruritus between the toes, and can spread to soles of the feet. In severe cases, inflammation, intense itching, pain when walking, and foot odor may occur. It is common in PT settings and can lead to bacterial infections, especially in older adults. Parasitic skin infections include scabies and pediculosis, which is also known as lice. Scabies is a highly contagious skin condition caused by skin mites. Worldwide prevalence is about 300 million cases annually. The mites burrow into the skin, laying eggs, and hatch into larvae. It is transmitted through skin-to-skin contact and contaminated objects. Risk factors include HIV and immunocompromised conditions, increase individuals' risk. Clinical manifestations of scabies include intense pruritus, worse at night, excoriation from scratched skin, burrows which create linear lines with vesicles at one end with the mite inside. Commonly infected area is interdigital spaces, flexor wrists, axilla, waistline, and umbilicus. Also genitalia in males and nipples in females. Diagnosis is done through mite extracted from the burrow and examined under a microscope. Long-standing cases may require presumptive diagnosis. Treatment includes scabicides, which is permethrin or other type of cream that is applied from the neck down, as well as oral therapy. Next, we're going to talk about skin cancer. First are benign skin lesions. Seborrheic keratosis is a hereditary benign proliferation of basal cells, usually appearing after middle age. It can occur after hormonal therapy or inflammatory dermatosis. Appearance is waxy, smooth, and raised lesions. Color is yellow, beige, dark brown, or black. Common sites include the chest, back, and face. Nevi, or moles, are pigmented or non-pigmented lesions formed from melanocyte aggregation and developed early in life. Their appearance is pale brown, black, or flesh-colored, and can appear singly or in groups. They vary in size and thickness. Precancerous conditions include actinic keratosis, which is abnormal cell growth from chronic sun exposure. The appearance is crusty, rough, sandpaper-like patches or bumps. Common sites include face, ears, lower lip, scalp, and hands. Bowen's disease, or squamous cell carcinoma in situ, is early stage squamous cell carcinoma that affects both exposed and unexposed skin. It can appear on mucous membranes and is associated with arsenic exposure in youth. The appearance is brown to reddish brown, scaly plaques, and has well-defined margins. Malignant skin neoplasms include basal cell carcinoma, which is a slow-growing skin cancer from undifferentiated basal cells in the epidermis. It rarely metastasizes but can cause local tissue destruction. Squamous cell carcinoma is the second most common skin cancer in Caucasians and arises from epidermal keratinocytes in sun-damaged skin. Common sites include ears, face, lips, and hands, and is rare in dark-skinned individuals. Malignant melanoma is cancer of melanocytes. It is the most common in skin, but can also occur in the oral cavity, esophagus, anus, vagina, meninges, and eyes. Kaposi sarcoma is malignancy of vascular tissue, primarily affecting the skin. It is common in older Mediterranean and Eastern European men. It is strongly linked to AIDS-related immunodeficiency and also seen in kidney transplant recipients on immunosuppressive drugs. Skin disorders associated with immune dysfunction. Psoriasis is a chronic autoimmune skin disorder causing rapid skin cell turnover. Clinical manifestations include red, raised plaques covered with silvery scales. Common sites include elbows, knees, scalp, lower back, and symptoms include itching and discomfort. The etiology is there is an unknown exact cause, but involves genetic and environmental triggers. Cutaneous lupus erythematosus is an autoimmune disorder affecting skin tissue. Clinical manifestations include red, inflamed lesions and may have a butterfly-shaped rash over the cheeks and nose. Scarring and pigment changes are possible. Types include discoid lupus, which is localized round scaly patches, and subacute cutaneous lupus, which is more widespread involvement. Systemic sclerosis, also known as scleroderma, is a progressive autoimmune disease causing skin and connective tissue hardening. Clinical manifestations include thickened, tight skin, which may cause contractures and restricted movement. Commonly affected areas include hands, face, and extremities. Internal involvement involves the lungs, the heart, and kidneys in severe cases. Subtypes include limited scleroderma, which is mainly affects skin of hands and face, and diffuse scleroderma, which is more widespread, often involving internal organs. Polymyositis and dermatomyositis. Polymyositis is an inflammatory muscle disease which leads to weakness in proximal muscles. Dermatomyositis is similar to polymyositis but includes skin rash. Clinical manifestations with polymyositis include proximal muscle weakness, specifically shoulders and hips, difficulty with stairs, rising from a seated position. Dermatomyositis clinical manifestations include violet red skin rash over eyelids, face, neck, and back. Etiology is autoimmune related and triggered by genetics and environmental factors. Thermal injuries include burns and cold injuries. Cold injuries are caused by overexposure to cold air or water and can result in localized injuries such as frostbite or systemic injuries such as hypothermia. Frostbite is tissue damage, gangrene, potential amputation if untreated. Hypothermia is a serious medical emergency where the core body temperature drops dangerously low, affecting organ systems, especially the central nervous system and cardiovascular system. Burns is damage caused by thermal or heat, chemical, electrical, or radiation sources. Severity depends on temperature, energy source, and duration of exposure. Severity assessment includes risk of infection, mortality, and cosmetic or functional disability. Burn classification includes first, second, or third degree based on tissue damage and treatment needs. Here you can see a graph that depicts the superficial burn or first degree burn, causes, appearance, sensation, and course. Partial thickness burns or second degree burns, full thickness burns or third degree burns, Here is a document showing the rule of nines. The purpose is to assess burn extent and fluid resuscitation needs. For the adult body surface area breakdown, the head and neck account for 9%, each arm 9% or 18% for both, each leg 18% or 36% for both, front torso 18%, back torso 18%, and perineum 1%. In children, proportions vary due to larger head and smaller legs. Treatment of burns includes, for minor burns, clean the wound and remove debris, remove damaging agents, debride non-viable tissue, apply antimicrobial cream and sterile dressings, and blister management including careful debridement and let the blister break naturally. In major burns, life-saving measures such as airway, breathing, and circulation should be implemented first, then infection control, wound care, skin grafts, and pain management. PTAs assist in acute recovery for functional and cosmetic outcomes. Therapeutic interventions include wound management, which includes irrigation, debridement, and advanced wound dressings, positioning and immobilization, especially after skin grafts to prevent graft damage, scar and contracture prevention with interventions such as stretching, exercise, and proper positioning, exercise and ambulation to promote recovery and mobility, and ADL management to support functional independence. Scar management can include elasticized garments, which are worn for 1 to 2 years to reduce hypertrophy and improve appearance, and bioengineered dressings, which are temporary biological dressings that minimize fluid loss and prevent infection, as well as reduce pain. Here you can see an assessment tool that is used for pediatric burns. Other integumentary disorders include pigmentary disorders, where skin pigment is mainly determined by melanin, which affects skin, hair, eyes, and certain nerve cells. Hyperpigmentation is excess melanin production causing darker skin patches. Hypopigmentation is reduced melanin production leading to lighter skin patches. Blistering diseases are where blisters form on the skin or mucous membranes. An example is a rare autoimmune disease where epidermal cells separate, forming blisters. Causes are often unknown and can result from viral or bacterial infections, skin injuries, drug-induced reactions, and autoimmune reactions targeting skin adhesion molecules. The primary population affected is middle-aged or older adults, though it can occur in any race, and it can occur in any race or ethnicity. Cutaneous sarcoidosis is a multisystem disorder characterized by granulomas or inflammatory lesions with phagocytes and lymphocytes. Common subcutaneous nodules, especially around the knees and elbows, will develop and may occur alongside pulmonary and cardiac sarcoidosis. Treatment involves systemic corticosteroids, often resolve the nodules. Integumentary ulcers or pressure ulcers are open sores caused by various conditions like diabetes, arterial insufficiency, radiation damage, systemic sclerosis, vasculitis, and prolonged pressure. Complications can lead to severe outcomes if untreated. Pressure ulcers are also known as bed sores or subcubitus ulcers and are caused by unrelieved pressure on the skin and underlying tissues, often over bony prominences. Pressure ulcers are staged where stage 1 pressure injury has intact skin with non-blanchable redness. Skin doesn't change color when pressure is applied. In dark skin, arrhythmia may not be visible, but temperature, sensation, and firmness may change. Stage 2 pressure injury is a partial thickness loss of skin with exposed dermis. May show a serum fluid-filled blister or shallow open ulcer. No fat or deeper tissue is visible, and common in areas like the pelvis and pelvis and heels. Stage 3 pressure injury is a full thickness skin loss with visible adipose tissue. Granulation tissue and rolled wound edges are often present. Undermining or tunneling may occur. Deeper tissue is not exposed. A stage 4 pressure injury is a full thickness skin and tissue loss, exposing fascia, muscle, tendon, ligament, cartilage, or bone. Undermining, tunneling, and slough or eschar may be present. Unstageable pressure injury is a full thickness tissue loss. The extent is obscured by slough or eschar. Once slough and eschar is resolved, it may be staged as stage 3 or 4. Stable eschar, if dry, intact, and without arrhythmia or fluctuance, it should not be removed. Deep tissue pressure injury is a persistent deep red, maroon, or purple discoloration of intact or non-intact skin, often preceded by pain and temperature changes, and caused by intense or prolonged pressure and shear at the bone-muscle interface. Guidelines for prevention of pressure ulcers include regular skin inspections, clean soiled skin, minimize dry skin and injury to skin, maintain mobility, reposition, and avoid dragging. Back to our questions. A 65-year-old patient with diabetes mellitus presents with a non-healing wound on the right heel. The wound is large with exposed adipose tissue and has rolled edges. There is visible granulation tissue, and the depth of the wound varies across the heel. The wound bed is moist and pink, but no muscle, tendon, or bone is visible. The patient reports mild pain, and the wound has been present for several weeks without significant healing. Based on the description of the wound, which of the following is the most appropriate classification of the pressure ulcer? The answer is C, stage 3 pressure injury. A stage 3 pressure injury is characterized by full thickness skin loss with visible adipose tissue and the presence of granulation tissue. The wound edges may appear rolled, and there may be no visible bone, muscle, or tendon, which fits the description of the wound. The presence of moist pink tissue and the fact that deeper tissues are not exposed supports this classification. A 45-year-old patient presents with chronic scaly erythematosus rash on their elbows and knees. The patient reports that the rash comes and goes and has worsened over the past few weeks. Upon examination, you notice silvery white scales on the patches of skin. Which of the following conditions is most likely responsible for these symptoms? The answer is B, psoriasis. The presentation of chronic scaly erythematosus rash with silvery white scales is characteristic of psoriasis, a common autoimmune condition that often affects the elbows, knees, and other extensor surfaces. Psoriasis involves rapid skin turnover leading to buildup of scales. The other conditions listed have different characteristics in terms of location, appearance, and triggers. If you like this video, please make sure to like and subscribe.